Hey Ben, can you hear me?
I can. I can't see you.
Oh, I may not have video enabled. Hold on. Start video.
There you
See
go.
me now?
Yep. I'm gonna mute you, Chris, just to start. Okay.
Oh, that's fine.
Hello, everybody. We're just wait a few more minutes here. We're just 4 o'clock. We're seeing who's gonna show up. No idea. You guys are welcome to turn on your video so we can see everybody. I think that would be nice, actually. There's Manit. We see Manit. Brian, Will, Anne. All right, Sean. Look at this. The crowd. Okay, we'll wait just another minute or two. Oh, my cat snuck in here. This is not good. It's just gonna jump on the microphone. I know it. All right, it's a good group. All right. If you don't have your video, no worry, but it'd be great to see you. See some faces. David, welcome. Everyone, welcome. Anne, nice to see you. You come in as on mute, just so you know. So if you want to talk, you have to unmute yourself. But I find that a little bit easier than the other way. It's a little less noise. So I don't know everybody, but just so everyone knows, I'm Ben Regal, founder of the RCM Leaders Forum, and if you don't know what that is, that's just a network of VPs of RevCycle and colleagues and some vendor partners, and we get together twice a year. Looks like once a year, maybe. So
once a year this year.
Once a year this year. Tina is my partner in crime in that. But I was talking to actually a few people, and they were all saying it'd be great to just hear what other people are doing and dealing with, and what's happening, and lessons learned, best practices. We did like a webinar for home, like sending people home and remote work and what that looks like. So I hope that was helpful if you guys, anyone joined that. But felt like there was other things that were happening, and certainly I know lots of people on the call are dealing with lots of stuff. So I don't know if anyone wants to kick it off with, like a question or what they've been seeing in the hospital world, but I'd love to get it kicked off.
I'm happy to dive in. First of all, Ben, thanks for sending out. This is Brian Robertson. I'm the CEO of VisIQuate.
Yeah.
We do analytics in the RCM space. I see some familiar names. I appreciate you throwing this out there on LinkedIn, it caught my eye. And I thought, wow, this new norm. It's great to meet new people and, use the wisdom of the crowd. So I just appreciate the invite and great to meet all of you and hope to add something to the fun today.
Yeah, I mean, we're all in it again, a new world. It's the unknown. So it's the unknown.
Yeah.
Anyone like to go first with a question? And I'll just say real quick, just the rules of obviously be respectful to everybody, but rules of the engagement, don't sell anything if you can help it. Just try to be respectful of everybody's time and everyone's going through something different. So, Minnie, I saw you raise your hand, so why don't you go first?
Yes. Hello, everyone. I'm relatively very early in my rev cycle experience. So what I wanted to anticipate or understand, given the current situation and climate with the coronavirus, what can revenue cycle, what can be expectations moving forward, and sort of the work backlog that'll hit the revenue cycle leadership and on the front lines after this is all come down to a safe and happy ending, hopefully. Not so happy, but so yeah, just kind of looking at the impact on the industry in general. What can be the major trends that we'll expect to see in the backlog and the backlogs of this?
So this is David Kelly. I think it's a good question. I think it's a question that a lot of us are probably asking ourselves. I don't know how many providers out there. We've seen approximately, depending on service line and whatnot, a 50% drop off in volume. So when you talk backlog, that's not what's manifesting for us, at least not right now. But as I'm in Ohio, we've not been hit by the surge, as a lot of people are calling it, in patients yet. But as we start to see that, and then afterwards, as people who couldn't get their surgery or they're this or they're that, swarm our schedules to try to get in this year, I think that's where that'll evolve. And what's that going to look like? I don't know, because I think that it's very likely gonna overwhelm our staff and our ability to keep up. So does that mean that everybody, all you wonderful vendors out there, who I've been sharing posts to politely, please not bother me, is it going to be the other way around? And I'm going to be messaging you going, please help, please help. I don't know what that's going to look like, but I think it's a great question and
well, David, have you seen
subject to evolution.
Have you seen just a technical question? Have you seen, I'm assuming ADR has dropped like a rock in most places. Like your average day revenue has to have dropped unless you've had a significant. So my guess is your AR days have actually climbed. Am I?
So I've mostly got physician. Well, I've pretty much entirely got physician realm.
Oh,
so what I've heard from the facility counterpart is that their days are looking like the best they've ever had. Ours are pretty flat. So because of exactly what you're talking about. So I mean, I think it depends on. I think one of the big X factors in that, at least for us, and in our markets, and what I've been reading is probably how assertive companies have also been with their need to furlough, right? Because if they've kept folks, like my prior employer, Meritan, I reached out to the CFO there, my former boss, and said, how are you guys doing? And he said, financial impact's not going to hit for 30 days. So we're working down the AR to try to get that cash bolus.
But once that's gone, it's like you
Right.
don't have this inventory. So your days, so
Right.
I guess my point would be days is not going to be a great metric to say
Concur.
for anyone because it's not
Yeah.
going to be comparable.
Right. There's no meaningful comparison as of any day now.
Because the swing and the ADR is too high, right? Yeah. I mean, Brian, would you agree with that?
Sure. So here, Ann Aidenbaum reporting from New York, the epicenter of it all. Our average daily revenue, which typically is measured on 90 days, is really not a great measure because our charges started really to decline the beginning of March. So right. More measured on a 15-day probably ADR. So yes.
That's crazy.
The cash I mean, the days in AR were good, but they're just, it's not an appropriate measure. In New York, there's the only ambulatory work that's going on is telemedicine, unless somebody really has to be called in. For those who don't know me, I'm with Weill Cornell New York Presbyterian, so one of the largest health systems in New York City. The number of patients who keep coming in, I mean, 2 weeks ago, maybe there were 200 patients. Now there's 2,000 patients across the system, and about 25% of them are on ventilators or in ICU beds. So, there's, as people say, the work queues for charges are really lean because that's really all people have to work on. All the surgeries have been canceled.
Right.
And they're just, desperately trying to find ICU beds because that's all they have a need for. So, the question earlier, what's it going to be like? I don't think we've ever, been in a situation like this before to really have a sense of what it's going to be like. And, and I've lived through 9/11 in New York. I've lived through Hurricane Sandy in New York, but those were all so temporary compared to this. And then, so the AR is really going to, the revenue, for the hospital, and I only manage involved in professional building. It's going to keep shrinking. No talk of furloughing staff because they need all the staff they can get for all kinds of activities. So that's our experience in New York. It's pretty dreadful.
What about others' experiences, other people's, what do they have? What is saying, Laura? I know you're in Arizona. Will, what about home health?
Sorry, I had to find the mute button. In home health, what we're starting to see is obviously DSO are dropping drastically. We're monitoring the census for all of our clients in home health, and we're really starting to see a significant drop right now. Mostly people don't want nurses coming into their homes. So we've seen telehealth jump. It is, again, we've got enough work for 30 or 45 days, but after that, it is a huge concern for the AR staff.
What's happening in telehealth? Are you figuring out how to bill that? Is anyone, are you getting that down? I know Janelle said earlier, I talked to Janelle, and Janelle runs US Medical, and she said they were just billing for it, but they weren't sure what was going to happen.
We're billing for it. I can't tell you we've gotten paid yet. But yeah, we're monitoring it.
Okay. Anybody else work at a provider that let's talk about what they're experiencing?
I can speak on behalf of our clients and all that we're doing on some of these trends and themes. I think that it's interesting. I've had some clients say that the next 90 days, the emergent surgeries and electives, of course, have just evaporated in 90 days, but then the demand curve is going to completely invert as soon as the dust settles. So they're thinking through what to do to prepare for that volume. So it's sort of like we see a lot of our clients doing short-term liquidity. How do they cover liquidity, especially if they're smaller providers?
Right.
And then longer term, how are they going to deal with the demand? Because a lot of this one client in particular has 30 surgeries a day, and it's the non-emergent gallbladders, bone spurs, total knees, total hips, nothing that required emergency surgery, but all things that, hey, my knee hurts, my hip hurts, my foot hurts. So they think that the demand curve is going to completely, turn upside down. And will they have capacity to deal with it when they're still, the effect of COVID? So nobody's got the crystal ball on those insights, but I think that's top of mind for a lot of our clients, how to facilitate at home. We're also doing a lot of things to just help people move to the home. But a lot of that, I mean, we're a SaaS company, so we're like, well, you can already do that. We've seen where IT departments have had to spend a lot of time making sure that they go from desktop, or yeah, excuse me, from desktop to laptop, use some kind of Citrix security certified, just so all of the apps of getting people at home. So we're trying to be as helpful as we can, but I think a lot of people are struggling with just having people that can run the revenue cycle. Some seem less impacted than others, especially those that have already moved to coding at home, some follow up at home. And I see a lot of people struggling with that we're offshoring ancillary work to India. There's been a really big impact on all of those ancillary India-based revenue cycle services. So,
Yeah, for sure. They basically can't work from home. They don't have the infrastructure to
that's
do
right.
it. Who's anyone experienced that? What are they how are they handling the offshore component? I wish Scott and Michael were on it because Scott, I know Scott's doing a bunch of offshore work.
So I have been in touch with Scott and Michael, and they tell me that both of their vendors have been able to have their staff, both of their Indian vendors have been able to have their staff work from home.
Oh, wow.
100%. I reached out to them because I have a colleague in New York who works at another institution who said that she had to bring that work back into New York in the midst of all this because for whatever reason, either that vendor couldn't get them to work from home or her institution. But Michael and Scott said they're working 100% with a 30-day kind of agreement to keep looking at it, from Epic agreeing to it and, you know, the institution. So some people are managing in India to get that staff to work from home.
Ben, this is Laura.
Hey, Laura.
We've outsourced our physician group through Cerner's business office solution, and so they actually use a whole India team for our account. And so far, they said that they have about 75% of their folks that they have been able to get working remote. So that's where we stand. We're just at the beginning of this, of course, so we haven't necessarily seen the impact, and it's our physician team, so smaller dollars, a little slower to see that impact, but that's what we were told by our Cerner group.
Yeah, no, that's good. That's good. That's interesting. So what, Laura, tell a little bit people like where you're from and what you guys have experiencing.
Sure. So I'm in Arizona. We're a 2-hospital system in northern Arizona, and we handle the majority of northern Arizona. We have a large Indian health population, which is, we have one of our reservations that's had some trouble here lately. So we have obviously seen a decline in our revenue, certainly with all the cancellation of the elective procedures. We haven't reached any sort of capacity or anything within our hospitals at this point in time. However, we do have an Indian health hospital that has nearby. What was interesting to me is that I expected to see our cash slowdown come within the next, 25, 30, 35 days. We actually saw that over the last few weeks. Right around the time that COVID was declared a pandemic, we saw a slowdown in some of our in some of our quick payers. And so that's starting to pick back up again, but we had about a 3-week slowdown in our cash, which was interesting to me. I didn't expect it until a little bit later.
Yeah, so you're saying insurances are slowing the cash down?
Mm-hmm. Mm-hmm. And so Blue Cross Blue Shield, for instance, Blue is a very fast payer for us. We typically see 75% of those payments coming in within the first probably 25, 26 days. And Blue Cross Blue Shield slowed down that week. Our payments declined by probably 35, 40% from them. Now, this week it started to kick back up again, but we had that 3-week lull. So we hit for March, we were extremely low on that cash, and then now it's starting to pick back up again for April. But then we'll be impacted in another few weeks just by the reduction in volumes.
Interesting.
So that was interesting for me. I didn't necessarily expect that. I expected the reduction in volumes to hit me in a few weeks, but not the slowdown in cash. So
I'm curious, Sean, I don't know if you can get on the, but what's John Muir seeing in California, since you're our lone California representative? Are you seeing a similar thing?
Yeah, yes. I'm preparing. Sorry, I'm not on video. I'm preparing for a meeting at 3:30. Yes, we're doing some cash prediction models right now that are they're just plummeting. And just gross revenues down. The ER's down by 50%. I'm seeing graphs right now. So yeah, it's just people are not coming in the hospital anymore, and the revenue cycle staff's at home, so they just can't get to the book of business. So it's just a huge slowdown.
Are you seeing payer slowdowns at all? Payers paying slower?
I haven't. My cash prediction model is now based off of late 2019 rates and timing, so I haven't updated it quite yet. It'll be interesting to see, but no, I just don't have enough payment activity in the last 2 or 3 weeks to make that that measurement.
Right. Interesting. Because I know you can imagine insurers are facing the same thing. They got to send people home. So
Yeah.
I know a lot of it's automated, but not all of it's automated. So it's interesting.
Well, a lot of them, Ben, the other thing is a lot of them, just like many of us here have offshore, a lot of them have offshore operations too.
Totally.
So yeah, they're in the same boat.
We always had this joke at Accretive and we were setting it up. I was over in India and we were like on the 10th floor, and United Healthcare had like a one floor below us, like the whole floor. We'd always be like, we're going to call the US and it's going to bounce back to the floor below. Which I always thought was funny. Anyways, my little joke. All right. No, that's good. What else? What else could be helpful?
I'm going to drop here in a second. I got to head into an afternoon call, COVID update. But Ben, I really want to say thanks. I want to say appreciate. It's about as casual I'll probably ever meet any of you guys digitally, I'm sure. But there's been a lot of folks in the vendor landscape who've been very helpful. I've gotten free coding guides sent to me because telehealth and the payers are doing changes like daily with coding. Some of the folks about, here's a white paper on productivity for remote work. Brian, you alluded to some of that before and trying to help your clients. So I've been trying to not be too critical in social media, because on the flip side, I have seen a lot of folks who are still trying to sell me stuff, and it's like, I have zero bandwidth for that. But those of you who are just being helpful, just, hey, I'm touching base. What do you need? I want to help. That's very appreciated, because again, in, I don't know what, 2 months or whatever, I think we providers are going to need that help, and we're going to need it rapidly. So appreciate that, and appreciate the opportunity to talk a little bit this afternoon and to meet some new folks as well.
Yeah, we'll just have it on the plan is to have it every Friday, 4:00. So if you guys want to join or get some more providers to join, that'd be great. We could just, if there's something to talk about, great. If there's not, that'd be even better. Because that means we're probably in a whole other spot.
Yeah. All right. Thanks, Ben. I'm not saying anybody else has to go, but I gotta go. So thanks, everybody.
Thanks, David. Yeah.
Bye.
Well, certainly would be helpful in the next, week or two. Are we really, seeing the apex like they're predicting we will, at least in New York, or is it just gonna, keep on going? The sky's the roof.
Right. Yeah, Detroit. Well, Tina and I are in Detroit, so
Yeah,
we're feeling the
just a little
same.
behind us.
It's just blowing up.
Mm-hmm.
Good. All right. Well, anybody else? I think it's been great. I know I don't want to take too much time. I thought we could just get together on Fridays and see where people are at, see if we can be helpful to each other. Oh wait, here's Kelly. You guys don't know Kelly, you should talk to her.
So Ben, one thing to offer, since people have mentioned coding, On our website, and I'm happy to send you the link, we do have a COVID resource page, and we're trying to have our own internal people look at as much specificity as possible. So down at the CPT code level, what's coming out from CMS. I know we all get a lot of the information, but we're coordinating with people at Ensemble and other clients to kind of use the wisdom of the crowd. So I'm happy to share that with folks because it's a lot of redundant information that anyone can look up. But we're trying to be helpful in that way to just have kind of an aggregator of all of those things that are really specific and tactical and tied to cash flow. We're trying to be, knowing that there's a lot of noise out there, our approach is to try to be helpful with things that impact cash.
Right. And speaking to that, does anyone know if they have a resource on, like, if you have a field hospital set up, how to get reimbursed for those things? Mark Wilczynski's from UVA has been asking, and I know he pointed to like a certain like AHA guidelines, but and like a waiver. I don't know if there's anything else. And if you, Michael, know anything about that?
Yeah, so the Boston Convention Center is being turned into a 1,000-bed field hospital starting, I think it'll be ready next week, and it's supposed to be, I believe, going to be under an MGH license. I don't know what the process is for doing that, but I know they're working through it. So I'm sure there are plenty of waivers that are being granted for those states that are, dealing with this.
Yeah, same also, New York Presbyterian's about to open up a field hospital in Upper Manhattan, hopefully by next week. In New York, we have the Javits Center that's just starting to be able to take COVID patients. And we also have the Comfort, but that is not allowed to take COVID patients. And they brought this big ship up here, and at the moment it has about 20 patients on it. So I'm not certain how people are gonna bill for them. Find out.
Interesting. Yeah, we saw the news articles about the ship. People were like, so they can't take any COVID patients.
Right.
Yeah.
They're supposed to decant volume from the hospitals in New York, but
there's no other volume.
Yeah.
Right.
Right, exactly. And also they have, patients have to be transported by ambulance to a New York City hospital for evaluation before they can be taken to the Comfort. And the New York City hospitals are just so swamped with everything that they're doing.
Yeah, right.
That's just adding unnecessary work to them. So like everything else, everything's changing daily, hopefully for the better, as far as, regulations and processes.
How many of you have had to lay off staff at this point? I know Trinity laid off 2,500 yesterday just in Detroit. I don't know. I figured RevCycle would be somewhat untouched, but I've heard of outpatient registration areas being laid off for a period of time.
no, MGH has guaranteed everybody's salary for 8 weeks, and then they're reevaluating, and they're using a lot of us to be redeployed to clinical area to help support the clinical areas in administrative roles. But we haven't had any furloughs in Partners or MGH yet.
I've taken some of my front-end staff to help with customer service. We have a lot of patients resetting payment plans. I'm using them to work eligibility denials. And then we have a lot of testing that we're doing. So they're helping with specimen reg.
Okay. Welcome, Kelly. Why don't you introduce yourself since we don't see you on video?
Yeah.
I mean, Brian's in his t-shirt. Will's drinking a beer. I mean, you might as well. Both Brians are in a t-shirt. No, why don't you introduce yourself, Kelly, to the team?
Will to have the bartender the next time he saw him or her to get me a beer too.
I assumed it was a happy hour at 4 o'clock on a Friday.
I mean, it might as well be at this point.
Oh, I'm Kelly. I'm the Revenue Cycle Associate VP at UT Southwestern in Dallas.
So, Kelly, what are you seeing down there? What's happening in Dallas?
So we're not hit as much as everybody else. So I think about 3 weeks ago, I got most of my Revenue Cycle people home. city of Dallas is locked down until March 20th or May 20th now. So they've
May
extended
20th.
past April.
Yep.
But I mean, our hospital is only 60% full, so we haven't actually hit the peak of what they're anticipating. So we're still at very low capacity here.
And you're not seeing any outpatients, so your volume is just tanked.
Yeah, we're doing about 1,800 telehealth visits a day.
That's good.
Yeah.
That's a big improvement.
Yep, we got it up and running pretty quick. So that was good on our IT side. And then we just keep up with documentation changes every day. I do have a question though. So I just had this discussion on holding self-pay statements. So there's the specific COVID diagnosis, but then there's that broader list that Epic sent out in terms of holding statements or charge edits or any of that. So is everybody holding statements for everything or just uninsured or?
I can tell you that, this is Brian with VisitQuay. I can tell you that the very large pool of our clients are, just to be cautious and do QA, they are holding everything. They're coding everything with all the new codes, but they're not releasing it yet because they just want to triple check that they've got it accurate because it's all so new and in flux. Some are billing.
So we're holding all that stuff, but they're wanting to also hold all the self-pay. So let's say that I bill something out and it has a diagnosis of, I don't know, ear infection was one of them. And so if I adjudicate a claim and it comes back that there's a copay for that visit, like I just don't know about the volume that we would be holding for all the self-pay after insurance. We're holding all the stuff if it's unfunded, but they want us to hold everything. And I'm just like, how does that even get worked?
We're not holding everything, Kelly. We're only holding COVID-related activity now. So it's a flag, an FDA or a diagnosis code.
Okay, so just those three.
Yep.
All right.
I mean, if you hold all self-pay, it just would seem like the backlog of that would be enormous. Like, I don't know. You gotta send bills out. I mean, at some point people gotta pay.
Them, but you're right.
That's what I think. Our group is when it comes to self-pay. So I'm just like, really? So I have to call every insurance company, figure out if it was ERISA, make sure if it was COVID related or not. I mean, that just sounds like a lot of work to me. And if the insurance company adjudicated it with a balance, then I should send it out. But
I mean, they were really paying it before, Michael. So I mean, yeah. There's not gonna be that much of a difference.
Yeah, good point.
Yeah, Cornell's not holding statements. They were looking to hold COVID statements, and they were still sending patients to collections as of last week.
we are still sending people to bad debt. I haven't stopped that process because I have enough people on the phone that if they want to make arrangements, we're more than happy to reset their level. We'll redo their payment plan. We'll do all of that stuff for them. But if they don't attempt to call, then they're going to bad debt.
Laura, are you holding statements or no? Or holding bad debt?
We are not.
So you're sending out as usual, per usual.
We are. We're sending out a letter to all of our patients within our statements that just indicates that if you are having financial difficulties during this time, then contact us. We are going to defer bills as requested for 90 days. But if we don't get contacted, then we will go ahead and send to collections.
Oh, that's interesting. Are you getting much response with that? What's the response to the letter?
We're just now getting ready to send the letter out.
Oh, okay. Okay, gotcha.
It should go out next week.
You might actually get more people to respond just to get off the list somehow. Interesting. All right, Will, what are you doing on the home health side?
I'm making a note that I need to look into.
Oh, that's good.
Yeah.
That's
Home
good.
health isn't really our areas is mostly Medicare certified, so
right, you're not getting as many home.
you're not getting as much.
Yeah. All right, good. What else? Anything else? So Kelly and Michael, just so you guys joined late, we're just planning to have every Friday at 4, a little happy hour. Will started that. He brought the beer, so I'm just saying was like a thing now. But we'll just have it open and conversation. If you guys have questions, resources, that'd be great. So
I will say one other thing that we're doing is that all of our hospital-based, like OT, speech therapists, physical therapists that are now approved to do televisits, we're getting those credentialed under the professional side so that they can start doing those visits and not be totally out of work.
Okay.
cool. Excellent. Anybody else?
Ben, I apologize for joining late. Did we talk about how folks are what people are doing to predict patient cash and revenue over the next few weeks and months?
Yeah, we actually figured it out, and
Excellent. Can you
I
send me an
got the
email?
formula,
Thank
and
you.
we'll send that to you. It's no
See
big
more
deal.
patients? See
Yeah,
more patients?
it was. We solved that in the first 5 minutes. Really, it was
Thank you.
very easy.
Very
Now
helpful.
we did talk about, in all sincerity, we did talk about. We started talking about error days and just kind of like what people are seeing and how we don't think it's a metric you can use right now, because ADR's changed so much. Ann's using like a 15-day ADR.
Yeah, we're using 14. A
Yeah.
rolling 14.
It's really, which is this is ludicrous that we're even talking about that.
One of our hospitals is using a rolling 7.
That's crazy.
Even crazy. Yeah.
So no, I think it's a good question, and I was actually gonna say maybe next week we talk more about kind of how are people predicting cash and what their CFOs are asking them to do, because
Sure.
I imagine that you guys are getting bombarded by CFOs to give you information related to that. I don't know.
Yeah, absolutely. I can share. I'm not prepared now but I can share next week what we've created if folks find it all helpful. I'd be
Yeah,
happy to demonstrate that.
Yeah,
I've
I think
seen
that'd
what
be
Michael
great.
has. It looks really good.
Don't tell him that. He'll get an ego, and then it'll be tough for him to come back.
Yeah. All right. Thanks,
Yeah.
everybody. Have a good weekend. Bye-bye.
No, seriously, I think maybe next
Formula
week let's
not the data.
talk about that. I think if people are ready to talk maybe about how they're predicting cash and what they expect and what they're being asked from their CFOs, I think that'd be helpful.
Yep.
And Brian Unell, if you have any thoughts on that, that would be great, because I know you're like a wizard in that. So both Brians.
So Ben, can I ask a question if you don't mind? I know I joined a little late. You might have covered this in the intro.
No questions.
No? Okay. All right.
No, go ahead. What's your question?
I've been bumped around my house with the girls home doing school and the dog barking and my wife working from home as well. Are you in a closet?
Yeah. This is what I'm relegated to these days.
Okay.
No, it actually, in fairness, Tina and I recorded a podcast about sales. So if you're in sales, the vendor guys in this, check it out. It'll come out next week. But it has the best sound in the house because it's like there's a bunch of clothes in here, and it's a relatively small space. I was like, well, I'm just gonna keep it together. That way my kids don't like interrupt.
Yep.
Or, I don't know if you guys saw this video, but it was great. There was like this woman who's staying with her parents in Florida or something, and she's like a reporter. Did anyone see this? She's a reporter, and she's trying to do like a news bit, and her dad comes out trying to put a shirt on. She's like, "Dad, come on." Oh, it was great. Yes, I am in a closet.
Well, the acoustics are really good, to your point.
Yeah, they're great.
I mean, it's fantastic.
You have a new trend here. Closet conference calls.
Part of the new normal.
Yeah, exactly.
We'll be closet revenue cycle people.
That's something different. All right. Anything else? This has been great, guys. 4:00 Fridays. I don't know. We'll tell people about it. More people we get, I think the better it'll be. But
Thanks for hosting.
excellent.
Thank you.
All right.
All right.
Everybody have a good weekend. Stay safe.
thank
Bye-bye.
you.
Have a good weekend.
Thank you.
Have a good weekend,
Thanks,
everyone.
Ben. Thanks,
Nice
everyone.
to meet you.